I believe we can start.
Hello, good morning. I'm Mary Stephen. Welcome to the WHO Africa Media Briefing, which is taking place in collaboration with the APO Group. First, some housekeeping. We have translation in Arabic and French today. You can choose the language you would like to hear for the press conference by turning on the globe on the bottom right of your screen and select your language. François, please explain in French.
Bonjour à tous et merci d'être connectés pour ce point presse. Vous pouvez choisir la langue que vous souhaitez entendre. Nous avons aujourd'hui disponible l'anglais, le français et l'arabe en cliquant sur le globe traduction en bas dans la barre d'outils de Zoom. Pour vos questions, merci d'utiliser la fonction pour les questions et réponses et merci de préciser votre nom et le média pour lequel vous travaillez.
Merci François. Halim, please explain in Arabic.
أهلا ومرحبا بالزملاء الصحفيين للحصول على الترجمة باللغة العربية برجاء الضغط على علامة الكرة الأرضية المتواجدة بالجزء الأسفل على اليمين وللأسئلة بليز ضغط على علامة المكتوب عليها Q&A وبرجاء ذكر المؤسسة الصحفية اللي بتشتغل معانا.
Shukran Halim. Joining us from Brazzaville, the Republic of Congo, is Dr. Mashidisho Moeti, the WHO Regional Director for Africa. Welcome, Dr. Moeti. I will now let Dr. Moeti introduce the other panelists.
Thank you very much, Mary, and greetings and welcome to all the journalists and colleagues who are joining this press conference. Bonjour et bienvenue à tous nos collègues journalistes. So I'm very pleased to be joined today by Her Excellency Dr. Hala Zaid, the Minister of Health and Population of Egypt, which was the first country in Africa to detect a case of COVID-19. And Her Excellency Dr. Zaid will share the reflections on Egypt's response to this virus over the past year. A warm welcome to you, Your Excellency. Thank you for having joined us. And I'm also very pleased to be joined by Professor Peter Piot, the director of the London School of Hygiene and Tropical Medicine and a veteran of the fight against viruses, who will share those experiences and speak about his experience as a COVID-19 survivor and about how Africa's experience of this pandemic compares to other regions. Peter happens to have been my boss in the past as well. So a warm welcome to you, Professor Piot. So February 14th marks 1 year since the first COVID-19 case was confirmed in Africa. So today we're going to look back over a year of achievements, challenges, and learning as Africa has responded to the pandemic. In the first year of this pandemic in Africa, more than 3.7 million cases have been reported. And in the coming week, the continent is projected to pass a devastating marker of 100,000 lives sadly lost to this virus. The African continent accounts for only 3.5% of global cases and 4% of global deaths. African countries have risen to the challenge of COVID-19, but at huge cost to national economies, to the livelihoods of families, and to the development of the continent. In sub-Saharan Africa last year, the GDP fell by 2.6%, and the IMF predicts that Africa will be the slowest growing large region in 2021. So the socioeconomic impacts of this pandemic will have ongoing repercussions for several years in African countries. During the past year, Africa has experienced 2 waves of COVID-19. The first was contained relatively effectively with rapidly scaled up public health capacities, social measures like border closures and stay-at-home orders at huge cost, we've already said, but also innovative partnerships, including with the private sector, and the fortitude and perseverance of African communities. To overcome shortages of essential supplies, WHO and partners created, as an example of some of the response activities, the UN Supply Portal, which has shipped more than 3,400 oxygen concentrators, 70 million items of personal protective equipment, and 12 million laboratory tests to African countries. Now, the second wave, which appears to have peaked in January, has been far more lethal than the first. Deaths from COVID-19 have increased by 40% in the last 28 days compared to the previous 28 days. The increasing deaths from COVID-19 are a tragic warning that health workers and health systems in many countries are dangerously overstretched. The one-year milestone comes as the continent faces the spread of new strains of virus. Variant B1351, first detected in South Africa, has been detected now in 8 African countries, while variant B117, identified in the UK, the United Kingdom, has been detected in 6 countries on the continent. This week, South Africa announced initially that they would pause the rollout of the Oxford AstraZeneca vaccine because a study indicating that the vaccine is less effective in preventing mild and moderate infection with the new variant that is dominant in the country. The government also announced that they will now use this vaccine, but very much under trial conditions among older healthcare workers so that we can have better data on the impact of this vaccine on more severe forms of the disease. Yesterday, the WHO Strategic Advisory Group of Experts on Immunization, also known as the SAGE, recommended that countries use the AstraZeneca vaccine for priority groups, even if variants are present in a country, while further research is conducted. These preliminary findings highlight the urgent need for a coordinated approach for surveillance and evaluation of variants and their potential impact on vaccine effectiveness. WHO will continue to monitor the situation and provide updates as new data becomes available. We'll also be briefing countries and supporting their analysis of the situation for decisions about vaccine use. While a vaccine that protects against all forms of COVID-19 illness is our biggest hope, preventing severe cases and hospitalizations which overwhelm hospitals and health systems is crucial. If cases remain mostly mild and moderate and don't require critical care, then we can save many lives. So my message is to people, go out and get vaccinated when a vaccine becomes available in your country. Ensuring equitable access to COVID-19 vaccines and sustaining the public health measures are the critical priorities to overcome this crisis. In closing, I'd like to mention that the Democratic Republic of the Congo reported a new outbreak of Ebola virus disease in Butembo in the North Kivu province. So far, 2 people have been confirmed with the disease and both have unfortunately died, and 200 contacts are being traced. We, of course, will work with the government to overcome this outbreak as we have done in the past together with our partners. So I'd like to thank you once again for joining us, and I look forward very much to our discussion. Thank you.
Thank you, Dr. Moeti. And now to you, Your Excellency, Dr. Hala Zaid. As the first country to have a COVID-19 case in Africa, could you share Egypt's experience with COVID-19? Over to you, Your Excellency.
صباح الخير جميعا، وسيدة الدكتورة ماتشيديسو مويتي المدير الإقليمي لمنظمة الصحة العالمية في أفريقيا، السيد الدكتور بيتر بيوت المدير التنفيذي السابق لبرنامج الأمم المتحدة المعني بفيروس نقص المناعة المكتسبة، السادة الحضور. اسمحوا لي في البداية أن أتقدم بخالص التحية لكل من ساهم في تنظيم هذا المؤتمر الهام، وخاصة السيدة مويتي التي أعتز بدعوتها الكريمة لحضور هذه الفعاليات، وأجدد إعرابي عن خالص الشكر والعرفان للأطقم الطبية في بلداننا الأفريقية التي ما زالت تقوم بدور هام في مواجهة خطر وتداعيات COVID-19 تحت مظلة منظمة الصحة العالمية. ما زالت التضحيات التي تقدمها شعوب القارة الأفريقية كبيرة، والمسؤولية الملقاة على عاتقها فادحة، ولكننا ندرك حجم والتداعيات ونضع كافة الخطط والسيناريوهات المحتملة لمواجهة هذا الفيروس القاتل. السادة والسيدات، اسمحوا لي، أنا مش هلتزم بشكل كامل بما تم إعداده من كلمة، ولكن أود أن أشارككم خبراتنا في مصر وإحنا كنا أول دولة تسجل حالة يوم 14 فبراير 2020 في قارة أفريقيا، وقمنا وكانت أول دولة من أول 3 دول في العالم استجابة لنداء رئيس منظمة الصحة العالمية يوم 7 يناير 2020 لمزيد من الإجراءات الاحترازية في نقاط الدخول وفي المطارات. فكان مطار القاهرة والحجر الصحي في مطار القاهرة من أول 3 مطارات استجابة. خلال قيامنا بإدارة الجائحة كان عندنا وضع استثنائي. احنا دولة يقطنها أكثر من 107 مليون نسمة، فيها أكثر من 7 مليون مقيم من غير المصريين. لا نطلق عليهم لاجئين، لكننا نعتبرهم جزء من نسيج المواطنين المصريين. فكان مهم جدا ان احنا ناخد اجراءات احترازيه قويه جدا في قطاع الطب الوقائي، وكان اهم حاجه عندنا ان احنا ما نضعش سيناريوهات اداره الجائحه بما قامت به الدول التي بدات. يعني اذا كانت الجائحه بدات في الصين وبعض الدول الاوروبيه وامريكا والولايات المتحده الامريكيه وقاموا باجراءات محدده، الحقيقه احنا انتهجنا نهج ان احنا مش هنقلد هذه الدول. احنا عندنا سيناريوهات يجب ان احنا نحترم فيها او ناخد في اعتبارنا ثقافة المجتمع والبعد الاقتصادي للمجتمع، وكذلك الحفاظ على الارواح. وبالتالي انتهجنا سياسة المساحات المستهدفة وليس المساحات الجماعية. يعني كنا بنعمل PCR للحالات اللي عندها اعراض فقط، وما زلنا، ولم ننتهج سياسة الإغلاق الكامل. عملنا إغلاق مؤقت وجزئي لمدة شهر، وكان ابتداء من الساعة 7 مساء لغاية الساعة 6 من مساء اليوم التالي. ولم نوقف الأنشطة الاقتصادية ولا الصناعية، وكان في توازن بين الحياة وبين الإجراءات الاحترازية، وده الحقيقة نجح في إدارة الأزمة والتخفيف من الآثار الاجتماعية والاقتصادية. وسجلت مصر تاني دولة في العالم في النمو الاقتصادي بالإيجاب، وسجلنا عدد وفيات حوالي 9500 وفاة و170,000 إصابة فقط على مدار هذا العام. ولذلك يعني استجبنا في الموجة الثانية بالدروس المستفادة في الموجة الأولى، وقوينا من موديل العزل المنزلي. لم نستخدم أكثر من 30% من إمكانيات مستشفيات مصر في الرعاية المركزة والتنفس الصناعي. لم توقف أي جراحة تداخلية حرجة أو حتى برامج الكشف المبكر عن سرطان الثدي. وانخفض عدد الوفيات من الأورام بنسبة تزيد عن 30% عن العامين السابقين، نتيجة إن احنا حافظنا على النظام الصحي ولم نوقف التداخلات الطبية الحرجة أبداً على مدار هذا العام والعام السابق. ولكن أحب أن أنا كمان أقول أن مصر من خلال دورها في أفريقيا لم توقف المساعدات لكل الدول الأفريقية الخاصة بالأطفال أو الأمراض المزمنة ومبادرة السيد رئيس الجمهورية لعلاج مليون أفريقي من فيروس سي وفيروس بي شملت كثير من الدول الأفريقية منها تشاد وجنوب أفريقيا والسودان وبعض الدول الصديقة. عفوا مش جنوب أفريقيا، جنوب السودان والسودان وتشاد وبعض الدول الصديقة. ومن خلال الصندوق الأفريقي الذي قام الاتحاد الأفريقي بإنشائه لمواجهة كوفيد-19 استطاعت مصر أن تقدم مساعدات ل 30 دولة أفريقية من مستلزمات وأدوية الكورونا بما يقدر ب$4 مليون. ويبقى التحدي المهم جدا هو طبعا مصر شاركت في الكلينيكال ترايلز والابحاث السريريه لانتاج اللقاحات، وكنت احد المشاركين والمتطوعين في الكلينيكال ترايلز وفي لقاح ساينوفارم، وكانت تجربه فريده ومهمه جدا هذا النوع من التضامن في الابحاث الإكلينيكية. مصر كذلك شاركت في كل الأبحاث التضامنية مع منظمة الصحة العالمية للخروج بأدوية وبروتوكولات علاج، وشاركت كافة معلومات المرضى عندنا تم مشاركتها مع كافة الجهات، وقمنا بنشر كثير من الأبحاث في أقوى المجلات العلمية منها اللانسيت ونيو إنجلاند جورنال أوف ميديسين. يبقى اللقاح والتحدي في أن اللقاحات تستحوذ عليها شركات محددة ودول محددة، وإمكانية أن احنا ناخد الكمية الكافية من اللقاحات ده دور منظمة الصحة العالمية والجافي. وفي هذا السياق أشكر السيد سيس بيركلي رئيس الجافي، وأشكر السيد تدرس أدهنم رئيس مدير عام منظمة الصحة العالمية لإصرارهم على إتاحة اللقاحات للدول المتوسطة والقليلة الدخل، وده أنتج إن إحنا بدأنا إن شاء الله هناخد جزء من اللقاحات اللي إحنا سجلناها في الجافي ابتداء من آخر هذا الشهر. ومع ذلك إحنا الحمد لله تلقينا جرعات 3 شحنات من ساينوفارم ومن أسترازينيكا، وبدأنا تطعيم كل الأطقم الطبية في مستشفيات التي تقوم بمواجهة الكورونا، والآن بنقوم باللقاحات الخاصة بباقي الأطقم الطبية في المستشفيات الأخرى. وطبعا أولوياتنا كبار السن والأمراض المزمنة. أدعو يعني المجتمع الأفريقي وأدعو كافة الشركاء إن إحنا نقوم بأبحاث تضامنية ونتبادل المعلومات والخبرات اللازمة للاشتراك في هذه الأبحاث لمشاركة العالم في الوصول إلى لقاح فعال أسوة بالشركات والدول والمؤسسات الكبرى. وطبعا يهمني جدا ان انا اشكر منظمه الصحه العالميه على المجهود الكبير اللي قامت به لدعم الدول ومصر منها، وكان اول اختبارات PCR تقوم مصر بعملها كان موجه من منظمه الصحه العالميه، واول PPEs اخذناه هديه من منظمه الصحه العالميه، وما زلنا بنعمل مع الإمرو بشكل كبير جدا. وبشكر الدكتور أحمد المنذري على المجهود الكبير والدؤوب في مساعدة كل الدول في المنطقة وعلى رأسها مصر. لا يفوتني أن أتقدم بالشكر للأطقم الطبية التي ما زالت تقوم بدور كبير جدا في دولنا الأفريقية لإنقاذ العالم أو إنقاذ شعوبنا، وكذلك كل الأطقم الطبية في كل أنحاء العالم. وأدعو أن القنوات الإعلامية والصحفية أن تبذل مجهود أكبر للتصدي لأي معلومات خاطئة سواء عن الكوفيد-19 أو عن اللقاحات، لأن هذه المعلومات الخاطئة تكون أشد فتكا من الفيروس نفسه. أشكركم جميعا وأشكر السيدة مدير منظمة الصحة العالمية لإفريقيا والمدير الإقليمي، وأشكر دكتور بيتر بيوت. وإن شاء الله جميعا إحنا مع بعض نقدر نرسم تجربة إيجابية للعالم كله في مواجهة هذا الفيروس بإمكانيات الدول الأفريقية المحدودة ولكنها المؤثرة بشكل إيجابي. والحمد لله إن احنا ندير هذه الجائحة بدون ما نؤثر على اقتصاديات الدول ولا نوقف الأنشطة. أخيرا بذكر إن مصر نظمت الشهر الماضي بطولة كرة العالم، كأس العالم لكرة اليد، ولم تسجل أي حالة إيجابية في ال 32 فريق أو الأطقم المساعدة أو القائمين على البطولة، وعددهم 5000 أقاموا عندنا لمدة شهر، ولم تسجل أي حالة إيجابية نتيجة اتخاذ كافة الإجراءات الاحترازية لعودة هذه الأنشطة للعالم، ليعود العالم إلى ما كان عليه ويبقى الإنسان وحبه للحياة عنصر مهم جدا لازم يتم الأخذ ليه حتى لا نخرج من هذه الجائحة بتغير سلوكيات البشر بشكل يصعب تعديله. شكرا لكم جميعا.
Shukran, Your Excellency Dr. Zaid. Thank you once again for sharing this interesting experience. We have definitely come a long way in this COVID-19 response. And now let's go over to the veterans in the field of virology. Professor Peter Piot, how do you see the evolution of the pandemic on the African continent compared to Europe? Over to you, Prof.
Thank you very much, Mary, and thank you, Dr. Moeti, for inviting me and also to share the platform with Her Excellency. And thank you, Dr. Moeti, for your leadership in dealing with this difficult epidemic. We're indeed at a sobering, milestone, and I think we have to realize that we are only at it's the end of the beginning, perhaps, but certainly not yet the beginning of the end of this crisis. That's the sobering reality. And Dr. Moeti said the economic impact and the impact on livelihoods of people is enormous in addition to the public health, impact. But I would say that certainly Africa has much to be proud of for the initial response. And it certainly did much better than Europe. I mean, Dr. Moeti mentioned nearly 100,000 deaths for the continent. Well, I can tell you that, was it the last week or about 10 days ago, in the UK, it passed the mark of 100,000 deaths just for one country, for the UK. So just to illustrate that there are no lessons to be given out of Europe, certainly in terms of the response to the pandemic. And I think one of the reasons is that many leaders responded very early on and in a coordinated manner with swift implementation of public health measures. And we know from experience, so be it from HIV or from Ebola, that when it comes to epidemics, early action is critical. That's why the title of my memoir is No Time to Lose. It's really because in contagion, when you act early, you don't only prevent the first case that could be contaminated, infected by one person, but all the subsequent cases. So acting early is really important. And I think that the fear that I had that originally there would be a major epidemic was did not materialize. However, as Dr. Moeti said, now we're quite in a different situation with major impacts across many countries that are heavily hit by COVID. And I think that the lessons from previous big epidemics are still there. The biggest of all in recent history for Africa and for the world, of course, is the HIV epidemic. Collectively, 35 million people have died. And here I would say that originally there was much denial with some exceptions. And again, it's the countries that took this on earlier on had the best impact. And this is a time when Dr. Moeti and I, we worked closely together. It seems like a long time ago, but HIV is still there. It has not gone away. But the big difference, of course, is that there has been a wake up. I think a turning point was in April 2001, in April when in Abuja, President Obasanjo, who was then the chair of what was then called the Organization of African Unity, convened a summit where every president said, yes, we have a problem and we must do something about it. And that's the first step. And since then, there has been really much progress. Certainly, mortality has gone down. And that's thanks to the introduction of antiretroviral therapy. But here the lesson is also, let's not forget that it took about 10 years between the announcement that antiretroviral therapy prevents death. It's not a cure, but it prevents you from dying from HIV. That was done in 1996 at the conference in Vancouver in July. It took 10 years before 1 million Africans benefited from access to antiretroviral therapy. We cannot afford today to have the same pace, and time for access to vaccines and therapies which are not there. So that's a very important lesson, that leadership is so important. And secondly, Ebola outbreaks until 2014 were always limited to Central Africa. With the first ones identified in what was then called Zaire, now Democratic Republic of Congo. And it was thought to be like a Central African problem, and with outbreaks now and then. And as we heard from Dr. Moeti, we still have again 2 cases in Kivu, in Butembo. But the whole perception and the reality changed when there was this huge epidemic in West Africa involving 3 countries, Liberia, Sierra Leone, and Guinea. And so that's something that was, again, earlier action could have prevented more deaths. But again, at the end, just as for HIV, community mobilization was a key factor in controlling the epidemic, plus resolute action. And for Ebola, we have a vaccine. For HIV, we still don't have a vaccine. This is like nearly 40 years after the isolation of the virus. But because of many, many technical difficulties, for Ebola, we now have a vaccine. Now, another, I must say, consequence of the crisis of the epidemics of be it HIV or Ebola is that many countries have now much stronger public health institutes and institutions and systems than before, but they're underfunded and it's very unequal among the continents. Now, just to come back to COVID, a few words before ending. One is that, as Dr. Moeti said, we're facing not only a new situation, spread of the virus, of the coronavirus, but also of new so-called variants. Now, viruses mutate. That's what they do to adapt, to survive. And but when millions of people carrying the virus, it's unavoidable that there will be new variants and so coming up. And that's a new challenge, not only for Africa, but for everywhere. And the effectiveness of vaccines, of course, is a big issue. But the truth is also that as long as one country in the world is affected by COVID-19, no country is safe. And that is really important. So having access to vaccines in Africa and elsewhere is not only a matter of, let's say, a moral issue of solidarity, but it's an imperative for everybody. Until Africans get the vaccinations they need, the whole world will suffer, as was said at the African Union summit last weekend by President Kagame. So remind me also that this is going to become one of the big geopolitical issues of our time, access to vaccination. And at the moment, there's scarcity. There are contracts, including for Africa, through COVAX and the African Union, of hundreds of millions of vaccine doses. However, the production, the manufacturing is lagging behind. And scarcity is a big enemy of equity. And so we need to really invest more in manufacturing, including in manufacturing that can happen in Africa. Let's not forget that, for example, one of the 4 yellow fever vaccines that are approved and are used in the world is made in Africa, is made in Senegal, you know, by Institut Pasteur. So it is possible to do this, but that requires more, you know, investments. And then finally, I would say it's not only about prevention and vaccination, but also about caring for those who are infected and affected. And Dr. Moeti mentioned the oxygen. And access to medical oxygen is really a key area where inequality reigns. Not only for COVID, but it's something that, you know, for neonatal care, for the many other areas. And I had that personal experience. So I was in a hospital, hospitalized in London, close to a year ago. I was one of the earlier people infected, and I survived and I recovered from my pneumonia and infection, thanks to you know, and I had severe oxygen deficiency, but thanks to this medical oxygen support. So I'm very, very sensitive to the fact that something as simple as oxygen can save so many lives. And again, that should be produced locally, should be available everywhere. And the gap between, you know, in low and middle income countries of oxygen is one of the defining health equity issues, I think, of our age. And so it, you know, 33% of COVID-19 deaths and 75% of child pneumonia deaths could be, you know, saved through this just availability of oxygen. So looking forward, I would say, to conclude, COVID has amply demonstrated that we can't afford to create a fire brigade once the house is on fire. That's why we need a WHO. That's why we need public health institutions in between these crises. And we need to invest more. So I hope that this is also a wake-up call for the world to get serious about the threat of epidemics and their prevention, because the risk is that we will have more and more pandemics because of you know, climate change, the destruction of nature, the interaction with you know, with animals, because these are zoonoses, and so we have to you know, to all work together. Thank you so much, and merci beaucoup, et je suis aussi prêt à répondre en français. Thank you very much.
Merci beaucoup, Professor Piot. It is indeed a great privilege for us, drawing from your wealth of experience dealing with outbreaks for decades. Thank you very much. We are joined by our colleagues, Dr. Richard Mihigo and Dr. Nsenga Ngoi from the WHO Regional Office for Africa. So now that you've heard all the panelists, it is your turn to ask your questions. To do this, please use the question and answer function on the Zoom application. Please remember, you will need to give us your name and the name of the news media you represent to have your question asked. We only take one question per journalist due to the volume we receive. And please indicate if you would like to go live by raising your hands. So going live this morning is Giola Foster from DPA. Can you please ask your question?
Thank you very much for the briefing. Can you hear me?
Yes, we can hear you. Go ahead.
Great, thanks so much. Dr. Moeti, after South Africa has halted its rollout of the AstraZeneca vaccine, its neighbor Eswatini also announced that it would stop its procurement of the vaccine through COVAX because of this recent efficacy study. So my question is, are you concerned that more countries will follow suit and reject the delivery of the AstraZeneca vaccine through COVAX, which is due to come in the next weeks? And just a quick second question, you mentioned 8 countries have detected the South African strain. Could you please clarify which 8 countries? Because in the previous briefing with Dr. Nkengasong from the Africa CDC, he spoke of 7 countries. Thank you.
Okay, thank you very much for those questions. I think, first of all, with regard to countries' reaction to the news about the so-called South African variant and the impact on vaccine efficacy, it's to some degree to be expected. And we are working very quickly to brief the countries, to provide them with the SAGE recommendation, which only came out yesterday. So the Eswatini announcement was made before this recommendation came out. It is our intention, and we've already started to send this information to all the governments to contact them and advise them, and to highlight the fact that an analysis of the risks and benefits with regard to using this vaccine needs to be made if this virus is not circulating very widely. And even if it is, we are recommending the use of the vaccine with an understanding that it may not be able to stop some cases, particularly milder cases, but it is able to stop a problem of severe cases. And it just so happens that Eswatini is one of the countries that is experiencing a second wave with very relatively high mortality rates. It's a small country. Its health system is struggling to cope with countries. So with the cases. So our intention is very much to contact the government through our office and to provide this advice, not only to Eswatini, and particularly to the neighboring countries, to South Africa, where the interaction is very intense. And we certainly know in several of those, this variant is circulating. Well, of course, supporting and advising all the countries in the region so that the benefit from this virus is not lost. So the countries in which this so-called South African variant is circulating include Botswana, Ghana, Kenya, the Comoros, Mozambique, of course, South Africa, and Zambia. One country, Tanzania, has not reported and is not working on the gene sequencing with WHO, but we are aware that 2 travelers from Tanzania have been found in another country to be carrying this variant. So possibly that's the country that might not have been mentioned by the Africa CDC.
Thank you, Dr. Moeti. The next question is from Nusa from Africa News. And this question goes to you, Professor Piot, and Dr. Moeti can complement. Among all the vaccines available on the market, which one is most appropriate for Africa, given the conservation capacity of African countries and the new variants?
Thank you very much for the question. I think we have to realize that we're at the beginning of several vaccines that will come on the market. And at the moment, the ones that are authorized are the messenger RNA vaccines by Moderna and BioNTech Pfizer, which have the highest efficacy. But the logistics can be quite complicated. And that may be okay. I mean, we shouldn't say, like some people saying, that it's impossible to vaccinate people in Africa because you need a cold chain or even -70 or so, because that's been done exactly with the Merck vaccine against Ebola that has been used on for hundreds of thousands of people, and is also to be preserved the same way at -70. However, I would say that at the moment, indeed, the AstraZeneca vaccine can be kept at just a regular fridge temperature, like other vaccines in the expanded program of immunization. And soon the vaccine made by Johnson & Johnson will also be in the market, which has the advantage of requiring only 1 injection, and which in trials in South Africa that were announced last week showed the very high efficacy, over 85% against severe disease and mortality. It's about the only vaccine that I'm aware of that was tested in Africa and that included enough cases of people with severe disease hospitalized and with, and then there will be Novavax also coming, which will be, is also easy to administer and to, in terms of cold chain, but there the production, I think, will come later on. So the key issue for me now is acting now, and then the production will come more and more, and then there will be more choice of vaccines that are more, let's say, affordable, because the price of like AstraZeneca and the J&J vaccine is much lower than for the other, the messenger RNA vaccines, but particularly the logistics. And logistics often determine, you know, whether the success of a program. Thank you.
Thank you, Professor. Dr. Moeti, do you want to compliment?
No, thank you, Mary. I think Peter has said this very well. I do not have anything to add to that. Of course, we want a vaccine that will be deployable eventually throughout the territory of our countries. And but I agree very much that it's possible to meet some of the challenges. It may not be possible to do so throughout the country. But what is fortunate is that we have a choice to use a combination of vaccines. That's also something that should be kept in mind. Thank you.
Thank you, Dr. Moeti. Now we are going live to Sarah from DVEX. Sarah, please.
Thank you for taking my question. Africa CDC today recommended that countries not roll out the AstraZeneca vaccine if the new variant is dominant in a country, but says that it's only dominant in South Africa. I just wanted to confirm that this is different than WHO recommendations based on the SAGE guidance. And how can we be sure that it's not dominant in other countries? And do countries have the capacity in terms of genomic sequencing to determine if it's dominant? And kind of how long will it take in terms of the scientific process for countries to determine whether or not the strain is dominant? Thank you.
Thank you, Sarah. Dr. Moeti, you want to go on this question?
Yes, thank you. You know, I think that there is not very much difference between the recommendation of the Africa CDC and what the SAGE recommended. Certainly, if the Africa CDC has said that if you like, the prevalence of this variant is high and it's the predominant variant present in a country, they should not use the vaccine. The South African government has decided to use this vaccine. WHO also recommended the use of this vaccine, but under certain conditions. It's going to be used in order to continue to observe the vaccine and study its impact, especially its efficacy, especially in severe disease. And I think that's something that has been done before. Professor Piot mentioned the Ebola vaccine. In the early phases, this vaccine was also being used under trial conditions. So it was possible to benefit from the vaccine, and it was also possible to continue to gather more data about its efficacy, etc. What's most important is to know what a country expects from the use of a vaccine. So if we're not expecting now to reach rapidly herd immunity in countries where this new variant is circulating at a significant level. But I think if a country realizes that it can benefit from preventing severe disease while understanding that the virus will continue to circulate, and therefore while being ready to strengthen and sustain other public health measures, I think this is perfectly acceptable. What's important is that the opportunity is there to continue to study the vaccine. And as I said before, that the vaccine is also used in other countries where the level at which this new variant is circulating is not so high. And as far as we know, it's only in South Africa that it's the predominant vaccine. Indeed, gene sequencing is something that has been initiated in a number of countries. WHO is working with the Africa CDC, and we're supporting 14 countries which are producing sequencing data but have not yet reported the variant. These are countries mainly in West and Central Africa. I'm mentioning this because it's very important to give the message clearly. These are countries in which the AstraZeneca vaccine can be used. And in addition, there are a number of neighboring countries to South Africa, Mozambique, Botswana, Swaziland, as I've mentioned, where this virus is circulating, and there is need for us to establish better the degree to which this is doing so. We are recommending that they go ahead to use the vaccine. So as with our partner Africa CDC, we have been supporting countries to establish their gene sequencing capacity where they don't have it. We've been helping with transporting specimens to a network of laboratories that do have this capacity. It's clear that this will have to be speeded up. The level of resourcing for this work will need to go up, and we will expand our capacity as WHO, working with the Africa CDC to speed up countries being able to detect this virus quickly and to be able to understand the degree to which it's circulating and incorporate it as part of their surveillance of the virus.
Can I say something here, Mary? Yes, I agree with Dr. Moeti, obviously, but I would also say that I fully support the decision by the South African government. Their situation is very particular, and what we need now is studies with the AstraZeneca vaccine that demonstrate clearly that it is, including people with, who require a severe disease. And so it's not a one-size-fits-all at the moment. And the SAGE, of course, has to make general recommendations. But I think here, I would certainly at the moment follow for South Africa the recommendations from the government there, which is based on some solid science. And I'm eagerly waiting for more results from trials involving the AstraZeneca vaccine. So thank you.
Thank you, Professor Piot. The next question is to you, Your Excellency, Dr. Zaid. This is from Miriam from Al Watan newspaper. She wants to know, is it true that the number of cases in Egypt will increase by April? Over to you, Honorable Minister, please.
أشكرك مريم على السؤال. طبعا احنا كنا متوقعين زيادة الحالات في شهر ديسمبر ويناير من ديسمبر 2020 ويناير 2021 لأن ديت بيبقى فيه زيادة في الأمراض التنفسية وبيبقى فيه إقبال من المواطنين على المكوث في البيت وتعرضهم لحاملين الفيروس بيكون أعلى. لكن هل متوقعين ان في زياده في شهر ابريل؟ هو الموجه الاولى في مصر كان بدايه الذروه ليها نهايه شهر ابريل 2020 وبالتالي احنا متوقعين ان احتماليات لو في زياده في الاعداد يكون ممكن يكون في ابريل زي ما حصل وحدث العام الماضي ولكن زي ما احنا عارفين وطبعا احنا امبارح كنت بعرض مقارنه الموجه الاولى بالموجه الثانيه ولقينا ان اكثر وفيات بتكون واكثر اصابات بتكون في الاسبوع السابع من كل موجه. يعني في مصر الموجه الاولى والموجه الثانيه كان اكثر اصابات في الاسبوع السابع واكثر وفيات طبعا في الاسبوع السابع. نتوقع ان لو هيمشي بنفس الترند بتاع بدايه الجائحه في مصر نتوقع لو هيبقى زي الموجة الأولى فممكن يكون فعلا بداية الارتفاعات في إبريل وذروة الارتفاعات في آخر إبريل وأول مايو وأنا أتمنى طبعا إن ده ما يحصلش تاني ولكن دي توقعات نتيجة الدروس المستفادة في الفترة الماضية. شكرا.
Thank you, Your Excellency. Then the next question, we are going live to Lisa from Voice of America. Over to you, Lisa, are you there?
I'm here. Am I unmuted? Because it's been a while since. Yeah?
Yes. Go ahead,
okay,
please.
Excellent. Thank you very much. Very quickly on the vaccine question, I'd like to know whether vaccines are beginning to be rolled out in Africa in substantial quantities. Last time I heard you, you thought that this might be the case. But I'd like to mainly ask you a question about the impact of COVID on efforts to contain the new Ebola outbreak in the DRC. Now, since there is a vaccine available, fortunately, for Ebola, and there now are vaccines available for COVID, do you recommend the use of COVID vaccines along with the Ebola vaccine, that this is something that would facilitate containing the epidemic? It's a very dysfunctional part of the continent, I'm afraid, and conflict and so forth. But do you think that this would facilitate containing the Ebola epidemic? Thank you.
Thank you, Sarah. Over to you, Dr. Moeti.
Yes, so our vaccines being rolled out extensively in Africa, not yet, but we are expecting very soon that to be the case. We have, within the COVAX facility, I mean, first of all, I have to say that there's a couple of countries that have started using the vaccines. These include Mauritius and Seychelles in the African region. And we know that in North Africa, which is our Eastern Mediterranean WHO region, in Morocco, Algeria is about to start as well, I believe. So what we are expecting, though, is two things. One, there is, as part of the rolling out of COVAX, it has been possible to procure some of the Pfizer vaccine for a number of African countries. So 4 countries are about to receive some supplies, not very extensively. However, it will give us the experience of using this vaccine. And then we are expecting that by the end of this month, we will have the emergency use listing of the AstraZeneca vaccine, of which through the COVAX platform, we're expecting to be able to eventually provide 96 million doses. So if you like, the substantive rolling out of vaccines, we expect to start in the latter part of February or early in May. We are working very hard with our countries to finalize their plans for the distribution and delivery of the vaccine. And about 34 of the countries on the continent already have their plans ready. So I'm really expecting that in March, we will start to see the rollout significantly of the vaccine. And then is it possible to do campaigns and interventions for both Ebola and COVID-19 in the DRC? Yes, I do believe it's possible. In the last outbreak in the Equator province, we were working, of course, on preparedness and then eventually on prevention of COVID-19 at the same time as vaccination and the response to that Ebola outbreak there was taking place. What will be needed would be to look at what in addition is needed, for example, in terms of cold chain delivery systems in order to work on these two problems at the same time. I do believe it's possible to do so.
Thank you, Dr. Moeti. Professor Peter, do you have anything to add on Ebola vaccine?
No, I totally agree with Dr. Moeti. The one thing I'd like to add is that also for Ebola, we have now 2 vaccines. One that is by Merck that is indicated, recommended for in case of an outbreak to to contain the spread of cases, and then another one also by J&J using the same platform, as they say, as for their COVID vaccine that could be deployed as a preventive tool, because ideally all healthcare workers in areas that are vulnerable to Ebola outbreaks should also be vaccinated, and that could be something that we should also think of. And then I totally agree with Dr. Moeti that the effort is the organization, the logistics. So why not give several vaccines at the same time? I mean, I don't think there is any, let's say, biological reason not to do that. And so totally agree. Thank you.
Thank you, Professor Piot. The next question is to you, Dr. Moeti. This question is from Dennis from SABC. Whose responsibility is it to vaccinate refugees, internally displaced persons, and stateless people?
Yes, I think, of course, we know that refugees very often face limitations in accessing healthcare services. But as part of international agreements, it is the responsibility of the host governments, as the refugees are part of the population that host governments that are within their geographic territory. So this is very much in line with the equities of the principles and values of equity that are being promoted at the international level as part of global solidarity. So governments that are signatories to some of these agreements, including to the collective action on the Sustainable Development Goals, accept this responsibility. What I think is also reasonable is, in the interest of equity, for these governments to be supported in order to carry out this function. Certainly it is their responsibility. And I think it's a little bit also a matter of self-interest. Refugees are part of the population, are in contact with the population. So if they are not being vaccinated, they will certainly remain as a source of risk to the rest of the population. In the same way as we are saying, if African countries are not having access to the vaccine, then the rest of the world will be at risk. So there will be a matter of solidarity, principle of equity, but also self-interest in ensuring that the entire population which is in the territory of a country is protected in order for the outbreak to be brought to a close in the country.
Thank you, Dr. Moeti. We have Alex who would like to ask his question live. Alex, are you there?
I am, thank you. Can you hear me?
Yes, please go ahead.
Thank you very much. This is Alex from Reuters in Johannesburg. So my question to Dr. Moeti is, South Africa said yesterday that it could seek to swap vaccine doses that it ordered directly from the Serum Institute of India via the COVAX platform. And the sense is they're swapped for a different vaccine. Do you have any comment on that? What do you think about that proposal? And the other thing is just, is quickly that the leader of the South African trial that found reduced efficacy against mild to moderate COVID-19 caused by the variant said he thinks it's highly likely that the Oxford vaccine or AstraZeneca vaccine is actually effective and could well protect against severe COVID-19 because it's based on a similar technology to the J&J vaccine. Do you think South Africa was a bit too hasty to pause vaccinations, given that we're in a public health emergency? Thank you.
Okay, I think I'll turn the vaccine question over to Richard, just to give him an opportunity to take part in this. The response in relation to the swap of vaccines in COVAX. Richard?
Yes, thank you, Dr. Moeti, and thanks for the journalists. Maybe before to respond to this question directly, the COVAX facility has provision for those self-financing countries to opt out for a particular vaccine that they are offered by the facility for a second choice once they've paid a different scheme of enrollment in the facility. So South Africa, right at the beginning, opted for that particular option. So it is something that in theory, it is possible. To which extent this approach will go up to the end, this is a completely different story, because for the moment, the availability of vaccine within the facility, as we know, are quite limited. So I think they can do that on the basis of the agreement that they signed at the beginning. But I think it will depend on the facility to have a variety of options in terms of vaccine. And with regards to the efficacy, I think Dr. Moeti, but we've heard also Professor Peter Piotr on the intervention that have highlighted probably the likelihood, but this has to be confirmed by the data of the efficacy of the AstraZeneca vaccine against severe cases and hospitalization, which is the ultimate goal for this vaccination strategy, because of the similar platform that's the one used by the J&J vaccine. But this has to be indeed confirmed in the data, and we believe hopefully that such data will emerge in the coming weeks to make sure that this vaccine can be rolled out quite efficiently in the country.
Thank you, Dr. Richard. The next question is coming to Moeti.
Oh, sorry, Mary. I just wanted to comment briefly on this, on the second question. Did I think South Africa was hasty in pausing? I think it's understandable that a country would wish to analyze again the situation, the risks and the benefits of a decision that it might take based on data, and then see what is the best way to handle the situation. You know, it just so happens that not only did this variant emerge in South Africa and the findings as we know them to be since yesterday, but also that South Africa happens to be going through a very severe pandemic. It is the worst affected country on the continent. It's a very big outbreak of this disease. And I think and their system, their healthcare workers, they've had many people infected and dying among the healthcare workers. The healthcare system has been severely challenged in some of the provinces to cope. So it is understandable for them to wish to stop, think, analyze, and consider several options of how to continue with the response, with the use of vaccines, trying to get the best impact possible in the shortest space of time. And that they've decided to continue with the trials and the studies and to look for data now in relation to older people, older healthcare workers, is a way to address both, to continue to use this vaccine, not in the way initially envisaged, and to see what they can do to acquire other types of the vaccines and continue with the science of understanding this better, because as we've already said, this is one of the vaccines that are best adapted to the context of an African country.
Okay, thank you, Dr. Moeti, for that addition. The next question is still back to you. This question is from Asahi, from AP. What does WHO intend to do on the increasing issue of COVID-19 in Tanzania? And what did the two travelers who were in Tanzania, the country, where are they coming from?
Okay, thank you. So to start with the second question, these two travelers went to the United Kingdom, I believe, and were identified there as having this variant of the virus. We are in continuous communication with the government of Tanzania at different levels. Of course, we have a country office and a country team, and have made it very clear to the government that WHO is available, willing with other partners to support the country to engage in response to the pandemic, which is what we recommend to all countries to do. We have been in communication in writing at my level as well, at the level of the WHO Director General, and we are continuing simply to offer our support through our country office, working with other UN agencies and sharing all the information that we are sharing with all other countries with the government of Tanzania, and of course also ensuring that through our communications, the people of Tanzania, other stakeholders in the country acquire the information that's needed to enable them to address the situation for the sake of the health of the people of Tanzania.
Okay, thank you, Dr. Moeti. So we are coming to the end of this media briefing. So we are going to give our panelists 1 minute each for their final messages. We will start with Professor Peter Piot. You will answer the question first and give us your final message. There is a question for you. Is Africa experiencing difficulties in the availability of oxygen? This is from Dakar too. Then your final message.
Yes, well, I think so. The data are clear that the oxygen is not available everywhere. So that's, for me, it could be part of strengthening health systems and also making sure there is local production. I mean, I don't have the figures here, but my message is, let's say, take the situation serious. I think we need really international solidarity to make sure that vaccines are available. That's I'm special advisor to President Ursula von der Leyen of the European Union, and so there is a commitment to also support Africa as much as possible. Vaccines, I think there will be more and more available, particularly in the next quarter. COVAX has committed to start sending about 90 million doses of vaccines to the continent in the end of February. So that's close. But we need to make sure that it's all, we're prepared for it. And that's the best guarantee also to bring variants under control, because the fewer people are infected and the more are immune, the less the virus has a breeding ground for this. So, but first of all, I would say great leadership in many countries, not in all, as we heard from Tanzania, for example, again, my tribute to Dr. Moeti's leadership and what you're doing. Thank you very much for everybody to be here. Merci beaucoup. Au revoir.
Thank you, Professor Peter Piot. Now to you, Your Excellency, the Honorable Minister of Egypt, Dr. Zayed. Your final message, please.
شكرا لكم جميعا. أولا بشكركم على هذا اللقاء المهم والمؤتمر الصحفي اللي عكسنا فيه خبراتنا. عندي بعض الرسائل أحب إن أنا يعني أأكد عليها. أهمية دعم منظمة الصحة العالمية لكل الدول لتغطية الاحتياجات الأساسية من الأدوية والمستلزمات، ده شيء مهم جدا. إحنا في مصر الحمد لله مواجهة الجائحة كان بالأدوية أو معظم العلاج، حتى العلاج اللي تم تطويره زي الريمديزيفير تمكنا من تصنيعه في مصر، فإحنا وفرنا أكثر من 98% من احتياجاتنا من الأدوية والمستلزمات والأكسجين من خلال مصر. مهم جدا النوع ده من الدعم للدول علشان تقدر تواجه الجائحة أو الاحتياجات الأساسية المستقبلية في كل الأمراض. رسالة الثانية عدم التركيز فقط على الجائحة وإهمال أو تقليل من شأن باقي التدخلات حتى لا تزيد الوفيات من الأمراض غير السارية والأورام وخلافه، وكمان التركيز على اللقاحات الخاصة بالأمراض الأساسية، لأن احنا زي ما احنا شايفين في أفريقيا زادت تفشي بعض الدول أو زادت إصابات مرض زي شلل الأطفال في بعض الدول كانت أعلنت خلوها التام على مدى سنوات طويلة من شلل الأطفال، وده نتيجة عدم التركيز على برامج التطعيمات الأساسية. الحاجة الثانية أهمية الاعتناء بالرعاية الصحية للاجئين والمقيمين من غير أبناء الدولة، لأن ده حقهم إنسانيا، بالإضافة ده إنه حماية للمجتمع. آخر حاجة إن أنا أعتقد إن اللقاحات ما زالت في طور التجربة حتى لو كان بيستخدم على مستوى كبير، وإن أنا بأثمن على جهود الشركات والدول في تطوير اللقاحات، وإن أنا لا أرى أن اللقاحات هي الحل النهائي، ولكن أحد الحلول، وإن مع التجربة ومع مرور الشهور والسنوات يمكن يكون في لقاح ناجع لكل أنواع التحورات في الكورونا. أشكر الكوفاكس على المجهود الكبير اللي بتقوم به لتوفير وإتاحة اللقاحات للدول المتوسطة وقليلة الدخل، وأشكر السيدة موتية على دعوتي لهذا المؤتمر الصحفي. وأنا يعني يسعدني ويشرفني إن أنا أكون يعني بشكل دائم معاكم في أي نقاشات. آخر حاجة بقول إن أنا دلوقتي بعكف على الانتهاء من تعاقد مع أحد الشركات المطورة للقاحات لتصنيع اللقاحات الكورونا في مصر، ومصر عندها تصنيع اللقاحات من سنة 1932. فإن شاء الله والعقد مع الشركة هيتيح توفير اللقاحات سواء لمصر وكمان لكافة الدول الأفريقية بأسعار لا تزيد كثيرا عن سعر التكلفة. أشكركم جميعا.
Shukran, Your Excellency, Dr. Zaid. And now to you, finally, Dr. Moeti, your final message, please.
Yes, thanks very much, Mary. First, again, my sincere thanks to Her Excellency, the Minister of Health of Egypt, and also to Professor Piot for having joined us today. And thank you for having shared your wisdom and your experiences with us and our journalist colleagues. I'd like to thank also the journalists for having joined us and for continuing your work of informing the public about this very important subject. And then just to finish, to say that, and add to something that Professor Piot said, it is, of course, a huge global geopolitical crisis that is being navigated. And that partially explains some of the difficulties in translating the intentions and the statements on equity into action concretely. But I think we can only continue to encourage those countries to do so because in a sense, we're all in it together. All the countries in the world are in it together. All the people in a country are in it together. And equity is one of the biggest drivers of inability to solve health problems in the world. So I think this is a test for all of us. Secondly, since we're pausing at the end of the year and reflecting back, I think one can only reiterate our advocacy for investment in health when we are not in the middle of a pandemic or a crisis, because this is what helps us to build the resilience, the systems that are able to detect quickly, to respond and to contain situations before they get out of hand. And then finally, again, going to appeal to our communities. We know that you are being bombarded with all sorts of information about vaccines that might discourage you from seeking this vaccine. I'd like to encourage everyone who has the opportunity when your turn comes in your countries to be willing to be vaccinated, because this is not only in your own interest, in the interest of your immediate family, but also in the interest of the country and in the interest of the continent. And finally, just a word of thanks to Your Excellency for your initiative to use the production capacity that we know exists in Egypt to produce vaccine for the rest of the continent. We've appreciated very much your country's solidarity with the rest of the continent in other health problems. So I'll stop there and thank you everybody for the work that you are doing against this pandemic.
Thank you, Dr. Moeti. A big thanks once again to our fantastic panelists. I believe we have learned a lot today. And thanks to all the journalists that joined us today. So for those that would like to ask more questions in French, our colleagues, Dr. Richard and Dr. Nsenga, will be on hand for the next 15 minutes. Thank you. We have come to the end of the conference. Have a nice day. Bye.
Bonjour, merci aux collègues et aux journalistes. Donc, nous allons maintenant prendre les questions en français. Est-ce que... Allô, est-ce que vous m'entendez, docteur Mihigo et docteur Ngoy?
Oui, on vous entend très bien, Khadija.
Oui, on vous entend.
D'accord. Donc, nous n'avons pas beaucoup de questions aujourd'hui, donc peut-être que d'ici la fin, d'autres questions vont venir. Donc, tout d'abord, il y a une question qui avait été posée, mais bon, ça serait bien qu'on revienne un peu plus là-dessus. À l'attention de Dr Ngoy, c'est une question de Youssoufa Amin de Dakar Actu. Donc, il est en train d'expliquer que Dr Moïti avait déclaré lors d'une vidéoconférence qu'avoir suffisamment d'oxygène commençait à être un défi dans la région. Donc, Youssoufa voudrait savoir, est-ce que notre sous-région est en voie de connaître des difficultés de disponibilité d'oxygène? À vous, Dr Ngoy.
Merci beaucoup, Youssoufa, et merci beaucoup pour la question. Je crois que Dr Moïti, dans la réponse aux questions et son introduction, avait fait allusion à ça. Je ne sais pas si le collègue avait pris ça. C'est un fait que dans la plupart de nos pays, nous avons un problème de production d'oxygène. Comme vous savez, la production d'oxygène et surtout la conservation demande des outils particuliers, en particulier des bonbonnes. Et dans la plupart de nos pays, les usines pour la production de l'oxygène ne sont pas courantes, on ne les trouve pas suffisamment en nombre d'abord et quelquefois seulement concentrées dans les grandes villes. Ce qui fait que la disponibilité de vaccins, quand la demande augmente, pas de vaccins, la disponibilité de l'oxygène devient un problème. Donc, dans la plupart de nos pays, c'est un fait que les hôpitaux, surtout quand ils sont submergés par les cas sévères qui nécessitent l'oxygénothérapie. Donc, c'est un fait. Maintenant, j'ai parlé des milieux ruraux où on ne trouve pas non seulement les usines pour la fabrication, mais même la disponibilité des bonbonnes d'oxygène eux-mêmes. Et même quand on a des équipements que nous appelons oxygène concentrateur, qu'on utilise au lit des malades pour essayer exactement de leur donner de l'oxygène, mais nous avons les rapports que dans certains pays, en milieu rural, c'est compliqué, puisque dans certains hôpitaux, déjà la disponibilité du courant électrique est un problème, puisque ces équipements travaillent sur le courant électrique, donc ça pose un problème. Comme Peter disait, c'est un problème de renforcement de nos capacités. Je pense que le COVID a révélé certaines de nos limites en matière de capacité de traitement, surtout des traitements des cas sévères dans nos hôpitaux. Et nous devons travailler pour renforcer nos capacités et nos systèmes de santé dans nos pays.
D'accord, merci, Dr Ngoy. À l'attention de Dr Mihigo, bon, je pense que c'est surtout pour une précision. Alioune Badara Diatta de Intelligence Magazine au Sénégal voudrait que nous précisions une chose. Il explique que Dr Moïti a cité 8 pays dans lesquels circulent les variants et il n'a pas entendu parler du Sénégal où les autorités sanitaires ont pourtant annoncé la présence du variant britannique dans le pays. Donc, est-ce que l'OMS pourrait confirmer cette information? À vous, Dr Mihigo.
OK, merci pour cette question. Effectivement, la précision de Dr Moïti par rapport aux 8 pays était en rapport avec la circulation du variant B1 235 plutôt, non 351, pardon, qui est le variant sud-africain, connu encore comme le variant 501YV2. Mais c'est vrai que nous avons eu des informations sur la présence d'un cas, je crois, du variant plutôt britannique. Donc, la discussion aujourd'hui était en rapport avec la présence du variant sud-africain dans ces 8 pays.
D'accord, merci, Dr Mihigo. Nous avons une question de Odile Harvey. C'est une journaliste basée à Bruxelles, donc elle voudrait savoir quels sont les pays d'Afrique qui utilisent déjà ou qui ont déjà postulé pour les vaccins chinois Sinopharm et Sinovac. Et elle a une deuxième question. Elle aimerait savoir quels sont les pays qui reçoivent des vaccins fabriqués en Inde. À vous, Dr. Mihigo.
Vous voudriez bien répéter la première question, s'il vous plaît?
D'accord. La première question, elle aimerait savoir quels sont les pays d'Afrique qui utilisent ou qui ont postulé pour les vaccins chinois Sinopharm et Sinovac.
OK. D'accord. Pour la première question, en ce qui concerne le vaccin, les deux vaccins chinois, Sinopharm et Sinovac, jusque-là, les Seychelles, qui ont commencé leur campagne de vaccination le 10 janvier, ont utilisé le vaccin Sinopharm, qui était plutôt une donation venue des Émirats arabes unis, environ 50 000 doses qui ont été utilisées dans le pays. Par contre, les autres pays qui ont introduit les vaccins jusque-là, au niveau de la région, ont plutôt utilisé le vaccin de AstraZeneca. C'est le cas de Maurice, mais également le cas du Maroc, qui a également utilisé ce vaccin-là. Et enfin, l'Égypte. Et enfin, l'Algérie, qui a plutôt introduit le vaccin russe, le Sputnik 5, fabriqué par Gamaleya Institute of Technology. Alors, en ce qui concerne la deuxième question, si vous voudrez bien encore la répéter.
Oui, elle voudrait savoir quels sont les pays qui reçoivent des vaccins fabriqués en Inde. Ah,
d'accord. Alors, pour le moment, le seul vaccin pour lequel la facilité Covid et COVAX a des engagements, c'est le vaccin de AstraZeneca qui est produit plutôt en Inde. Donc, le vaccin, par exemple, les vaccins arrivés en Afrique du Sud venaient de AstraZeneca, mais produits en Inde. C'est le cas également de ce qui s'est passé à l'île Maurice, mais également au Maroc, pour ce qui concerne les vaccins produits par l'Inde. C'est à travers une coopération entre le Serum Institute of India et AstraZeneca et Oxford University.
D'accord. Une question de M. Mahungo, Giscard Mahungu, de CIDEV. Bon, elle est un peu technique. Hein. Il voudrait savoir la capacité de surveillance génomique plus stricte est-elle possible dans tous les États africains quand on redoute même de la capacité structurelle de certains pays? Je ne sais pas si...
OK, ouais, je veux
prendre... Dr. peut y aller.
D'accord, Dr. Ngoy, allez-y, s'il vous plaît.
OK, non, effectivement, premièrement, je vais dire first. Premièrement, la surveillance génomique, elle est très importante dans les maladies virales, pas seulement dans le COVID. Même les collègues qui sont familiers avec la lutte contre la polio, ils savent qu'on fait la surveillance génomique. Et donc, la surveillance génomique, elle est très importante. Comme Peter a dit, le virus, sa nature, c'est de muter tout le temps. Et donc, nous devons capturer les mutations quand elles arrivent, et surtout les mutations qui ont une implication sur soit les modes de transmission, soit la transmissibilité, ou soit la sévérité de la maladie. Et maintenant, directement par rapport à la question, je vais être direct, la réponse est non dans la plupart pas dans la plupart, je vais dire. Dans certains de nos pays n'ont pas la capacité de faire la surveillance génomique, de faire le sequencing. Certains de nos pays n'ont pas la capacité. Et c'est pourquoi l'OMS, avec les partenaires, y compris Africa CDC, ils ont établi ce que nous appelons les réseaux pour la surveillance génomique, les réseaux africains pour la surveillance génomique. Ça veut dire que c'est un moyen de pouvoir appuyer les pays qui n'ont pas la capacité de faire la surveillance génomique à ce stade-ci, de pouvoir quand même accéder au sequencing, à faire le sequencing à travers un réseau de laboratoires, à travers des laboratoires dans d'autres pays africains. Et l'OMS a déjà travaillé avec certains pays pour envoyer les échantillons de leur pays vers certains pays africains, par exemple les Comores vers le Kenya ou vers l'Afrique du Sud, ainsi de suite, pour faire le sequencing. Et l'objectif, c'est que à travers ces réseaux, que nous puissions être en mesure de faire le sequencing des échantillons qui viennent pratiquement de tous les pays africains. Ça, c'est l'objectif immédiat ou à court terme. Mais l'objectif Et l'objectif à long terme, c'est pouvoir bâtir une capacité à long terme, une capacité de sequencing dans nos pays. Et nous sommes en train de travailler. Juste avant cette conférence de presse, on avait une réunion dans laquelle justement on discutait de cet aspect de long terme. Donc l'OMS y tient beaucoup pour pouvoir développer cette capacité dans la plupart de nos pays, si pas dans tous nos pays. Voilà.
D'accord, donc pour finir, en fait, c'est une question qui revient souvent, mais bon, je pense qu'on peut quand même la poser. Qu'est-ce qui explique médicalement la virulence et le taux de propagation plus élevé du variant sud-africain? Et également, l'Afrique semble mieux contenir la virulence de la COVID que plusieurs pays occidentaux. Qu'est-ce qui, selon vous, peut expliquer cela? Ce sont les dernières questions.
Ok, je pense que je peux y aller pour et puis...
Allez-y, s'il vous plaît. Et Dr Mihigo pourra rajouter...
Mihigo pourra compléter aussi. Premièrement, la maladie en général, je commence un peu par les aspects généraux d'une maladie et surtout une maladie virale. La sévérité dépend de trois choses, si je peux le dire. Ça dépend, du virus lui-même. Donc, il y a des virus qui sont plus virulents. Encore une fois, il faut entrer maintenant dans les détails virologiques, plus virulents, puisque bon, ils ont la capacité d'infecter rapidement ou de s'effixer rapidement au niveau des cellules, et aussi plus rapide, ils ont la capacité de se multiplier rapidement et la capacité donc de détruire plus rapidement les tissus ou les cellules qui sont infectées. Donc c'est un des facteurs qui détermine la virulence, le virus lui-même. Mais le second facteur, c'est la personne elle-même qui a attrapé le virus, si vous voulez. Si c'est une personne qui est déjà affaiblie, disons, soit par une maladie, par exemple, c'est comme ça que nous parlons de la comorbidité, ça veut dire quelqu'un qui a déjà une maladie chronique, par exemple, ou alors une maladie qui réduit sa capacité immunitaire. Donc, cette personne va être amoindrie pour se défendre contre les virus. Et donc, cette personne aura tendance à faire une maladie plus sévère, ou même le risque de mourir sera plus élevé. Et maintenant, sans parler de la virulence, mais en parlant de la mortalité des malades qui sont atteints par ces virus peut être influencée aussi, à part par la personne ou la caractéristique de la personne et la caractéristique du virus, ça peut être influencé par le traitement, la qualité du traitement. Et donc, si on peut être en bonne santé, peut-être, assez fort, le virus peut être de la même virulence, mais si la qualité de traitement reçu n'est pas bonne, donc le risque de soit évoluer vers une forme sévère ou le risque de même mourir, il est élevé. Donc, voici les facteurs qui influencent la mortalité, qui influencent la virulence. Je ne sais pas s'il y avait un deuxième aspect de la question, peut-être que je vous...
Dr Mihigo, vous voulez compléter?
Non, je pense que Dr Ngoy a parfaitement expliqué la situation. Je voudrais juste ajouter une petite chose en disant que effectivement, c'est quelque chose qui semble effectivement nous être donné. Il faudra que, comme nous l'avons entendu dans la première partie de cette discussion, nous attendre à ce que si quelque chose n'est pas fait rapidement pour arrêter la transmission de ce virus, il faudra espérer et voir dans l'avenir d'autres mutations qui vont arriver, parce que c'est ça la nature même des virus, et particulièrement les virus à ARN messager. Donc, je crois que c'est très, très important. 40 ans après, et plus, après la découverte du tout premier cas de VIH, du virus immunodéficience, nous ne parvenons pas encore, la science ne parvient pas encore à avoir un vaccin efficace contre cette maladie, en grande partie à cause de la nature même du virus lui-même. Donc, le message particulièrement par rapport à ça, c'est effectivement de voir dans quelle mesure nous pouvons vacciner rapidement un plus grand nombre possible de personnes, de manière à ce que, si les données actuelles se confirment dans l'avenir, nous puissions réellement mettre un frein à la chaîne de transmission et ne pas donner ainsi l'opportunité au virus de continuer à muter et éventuellement à se transformer et à infecter, se traduire un peu plus, à infecter plus davantage et malheureusement à échapper à l'action de certains vaccins ou même des médicaments. Donc, c'est une situation assez préoccupante, comme nous venons de le voir, pour laquelle il faudra absolument que la vaccination aille très rapidement pour être sûr que nous avons le maximum possible de gens protégés et dans un court délai pour ne pas donner la chance au virus de continuer à se multiplier et à muter.
Peut-être rapidement, si vous permettez, il y avait la seconde partie de la question sur pourquoi apparemment l'Afrique semble avoir été plus ou moins épargnée, si on peut dire, avec moins de cas que les autres régions. Effectivement, c'est une question qui revient souvent. Bon, maintenant, si j'ai dit la mortalité est déterminée par ces trois facteurs. Maintenant, si nous regardons en comparant l'Afrique et les autres régions, au niveau du virus, parce que nous avons dit que la mortalité peut être déterminée par les types du virus. Au niveau du virus, jusqu'à là, nous partageons le même virus. C'est vrai que maintenant, nous avons quelques variants, mais en termes de létalité, ces variants, non. Jusqu'à présent, l'information que nous avons, c'est que ce n'est pas une grande mortalité. Donc, la létalité reste la même. Donc, au niveau du virus, nous partageons le même virus. Maintenant, l'autre facteur, ce serait le facteur humain. Bon, les facteurs humains, jusqu'à présent, nous n'avons pas d'information que les Africains soient plus résistants à cause de leur race ou quoi que les autres. D'ailleurs, quand on regarde les pays multiraciaux comme les États-Unis, les personnes des races noires aux États-Unis sont disproportionnellement plus affectées que les autres races. Donc, on n'a pas d'évidence de croire qu'à cause de la race, l'Afrique serait plus protégée. Maintenant, quand nous regardons, nous serions aussi à même de pouvoir peut-être avoir peur, sachant que nos systèmes de santé sont plus ou moins faits par rapport aux autres. On s'attendait à ce que nous ayons une mortalité élevée. Mais ce n'est pas le cas. Alors, quelle est la raison? Alors, ce que nous disons, c'est que, premièrement, si vous avez tous ces facteurs égaux en même temps, les facteurs qui déterminent maintenant la circulation du virus et ses conséquences en matière de mortalité et de morbidité, c'est l'action humaine, c'est la première action. Donc, vous avez entendu Peter dire qu'une action précoce, décisive, elle est très déterminante dans la qualité de la réponse. Et nous pensons que l'Afrique a eu, en tout cas dans un premier temps, cette première qualité de réponse décisive dans les premières heures de la pandémie. Mais nous pensons qu'il y a aussi certainement d'autres facteurs. Peut-être qu'il y a d'autres facteurs qui ne sont pas encore étudiés, qui ne sont pas encore établis. Vous avez sûrement entendu des hypothèses quant à ce qu'on appelle l'immunité croisée. Il y a eu des études, personnellement j'en ai lu quelques-unes, qui ont finalement eu des résultats un peu contradictoires, les unes disant que oui, il y a une immunité croisée, les autres disant que non. Donc jusqu'à présent, ce n'est pas établi. Et donc pour le moment, les recherches doivent continuer pour savoir s'il y a d'autres facteurs qui auraient influé pour que les Africains soient épargnés, plus ou moins épargnés. En plus de l'action humaine et de l'action que nos gouvernements, nos pays ont pris au bon moment. Comme je dis toujours, ce n'est pas suffisant de prendre l'action, mais il faut prendre l'action au bon moment. Donc, la bonne action au bon moment, elle est très importante. Ouais.
Parfait, merci beaucoup, Dr. Ngoy, et merci à Dr. Mihigo. Donc, les journalistes également, vraiment un merci particulier à M. Giscard Mahungu, Youssouf Amin, Odile Harvey et Alioune Badara Diatta qui nous ont fait parvenir leurs questions. Donc, merci à nos experts et nous restons toujours en contact. Si vous souhaitez qu'ils répondent à plus de questions, vous pouvez nous les faire parvenir. Merci beaucoup, Dr. Mihigo et Dr. Ngoy, et à bientôt. Au revoir.
Okay, au revoir.
Au revoir. Richard, I talk. Hey, keep in going. I'll get in touch. Tari.
Hi, Collins.
Okay, no, I'll call later. That's all right.
Yeah, I think they were recording. I think it's over. They can maybe stop the recording.
Okay, let's leave there.
Thank you.
Okay.
Mm.